Why don't we jump into today's conversation? Let's invite our great panelists to come up on stage so we can start this conversation about US and Chinese approaches to COVID-19. We're having this discussion with all of you at an incredibly interesting moment for thinking about both how the US and China deal with COVID. It seems to be an incredibly dynamic and fluid situation. This is a theme that Cary and I have written about together in a project that I'm sure Cary will talk about in greater depth later. But just to say briefly, we are seeing that the zero COVID policy in China may be coming under some new strain given the rise of the Omicron cases in many different cities in China. And meanwhile, here in the US, on the one hand, it's a moment of relative ease at our University of Pennsylvania. We are not supposed to wear masks anymore. We don't have to wear masks anymore, which is a huge thing. But at the same time, we're seeing reporting about the rise of cases in Europe. And we know that the Biden administration officials who track these things are potentially going to foresee some kind of return to masking and other types of requirements here in the US. So first, we have Professor Cai Yi from Wuhan University School of Public Health, where her research interests include global health governance, public health security governance. She's published a book on public health security governance, A View of Global Health, published just in December, and lots of papers on China's practical response to COVID. Of course, she's in Wuhan, where all of this started, so she has been tracking this for quite some time. We also have Professor Ma Yun, my old friend, Associate Professor and Vice Director of Administrative Law from the Law School at the China University of Politics and Law. Professor Ma got her PhD at the Erasmus China Law Center at Erasmus University in Rotterdam, and her areas of research focus include public law, environmental regulation, and protected areas. Welcome to you both.
Okay, thank you, Nathan, for introducing our Chinese colleagues. Now let me introduce our American colleagues. First, we have Alexandra Phelan, who is Assistant Professor at the Center of Global Health Science and Security at Georgetown University. Also, she's an adjunct professor at Georgetown Law. She's also a global health lawyer and specializes on epidemics and pandemics. And our next speaker is Professor Cary Coglianese, who is Edward Shils Professor of Law and a Professor of Political Science at University of Pennsylvania. He's also the Director of Penn Program on Regulation. Professor Cary Coglianese specializes in the study of administrative law and the regulatory processes, with emphasis on the empirical evaluation of alternative processes and strategies, and the role of public participation, technology, and business government relations in policymaking. Welcome, both.
What a great group. And a good way to start, perhaps, would be to invite Professor Cai to say something about how you would best characterize China's COVID response up to this point. Of course, you're coming at this from the angle of public health. So especially from thinking about public health measures, could you say a few words about how our audience could best understand what are the main pillars of China's COVID response to this date?
Okay, thank you. Up to today, as you mentioned, China adopted the COVID zero strategy since August 2021 because of the Delta variant. And since August 2021, China have a lot of outbreaks in different locations across the country. So we cannot live in the normalized life since 2020 to 2021 August. So, but we should understand that the COVID zero strategy is not a strategy lasted for a long time. It's in the specific locations. It could be a community, residential community, or it could be a district, or sometimes it could be a city if the community transmission, it depends on the community transmission. So for example, if there is a community has the transmission and the community will be closed up, and then everybody should be staying home. And if you have a work, you should work from home. If you're a student, you should just study online. And then the community health centers will give everybody massive tests. Not infected in the 14 days, and if the local authorities will confirm that everybody in the suspended community are all free to infected by the COVID-19, and then the closed up, the community will be open again. So it will only last for 3 to 4 weeks. So I just want to explain why we implement this kind of COVID-0 strategy, because first of all, to Chinese culture, family members' life is very important. We don't want to lose anybody. So it's very important for Chinese people to save everybody's life. For example, if you research China's health expenses during the life course, they will spend all the monies on the health at the last 2 years. So it's very important. They would like to spend any money, any wealth to save like 1 month, 2 months life, even very short time. So it's very important to us to save every family member. And the other thing is like it's because of the limited health resources, especially the high quality health workforce in the rural China, because it's like more than 80% of high quality health workforce work in the three-tier hospitals in the big cities. So if we just let the people to move around freely, we have a big concern of the people living in the rural area. So that's why China have to implement the COVID-0 strategy. And the other thing is because the China has the environment, the background, the supportive environment to implement this COVID-0 strategy. So I published a few papers about, for example, the community engagement. It's not very easy, but it's very supportive by the public to support the policies. For example, the face mask, wearing face masks, everybody will follow that. They have no concern about it. And to do the vaccination, and they also can stay at home because of the not only for they don't have any concerns about staying home for 2 or 3 weeks at home, because there are a lot of supportive policies to support people work from home, living home, especially for the older people, disabled people. So the community workers will provide them different daily helps. So it's feasible for Chinese communities to close up for 3 and 4 weeks.
That's very helpful. Before we move on to another speaker, is influenced by the fact that the virus first came to light in Wuhan, your city, and that it was such a dramatic experience.
Actually, the timing and the location, because the 2020 January is the springtime to Chinese, and Wuhan is a very important transportation city. So a lot of people were transferred and will pass across Wuhan. So to Wuhan at that time, it's very important to contain the spreading. So we can say that it's the most difficult missions to contain the virus in Wuhan at that time. So if it happened in other cities, it may be resources kind of could be top 3 or top 5 in China, but it's still not enough, because when we analyze the health systems for prevention or controlling the virus is not necessary to have very high quality medical care or high tech equipment. It's because it's very necessary to have a very strong primary healthcare system. You should have the fever clinics in the communities, and most of patients, they don't need a very difficult, like high level treatment. You just quarantine them and they follow all the orders, and they would like to do that as a collective behavior. So to Wuhan, we still face the surge during the January of 2020, and because the other thing key is in China, because we can deploy a lot of resources, health resources and equipment and the food, everything to Wuhan at the same time. So the leadership is very important to contain the virus during the Wuhan's outbreak.
Leadership, that's a point that I think Cary may take up a little bit later too. But let me ask Professor Ma Yun to add some of her views. Of course, you're coming at it from the perspective that I know better of administrative law and regulation. And I know you've been looking at this issue quite closely in your work and have planned some international meetings around it. So how would you characterize China's COVID response to date from that perspective?
Okay, thank you, Nathan. I think the handling of this novel needs and also strength of Chinese administrative state, we all see that a regional concern is about the potential concealment of information. So legal reform is one of the initial regulatory responses taken by Chinese government. First, by amending the wild animal conservation law, pushed by a ban on consumption of wild animals, then enact a biosafety law. The hard law approach, China has also developed a handful of soft law measures or norms. For example, the National Health Commission issued and periodically updates the diagnostic treatment protocol and the guidelines for using masks, and also the guidelines for resuming work and production, etc. So all these soft law measures have shown their advantages of flexibility, participatory, and also experimental nature in comparison with the hard ones. But some soft measures turn out to be not soft enough, but hardened somehow. At the policy level, He has explained the dynamic zero COVID policy to deal with some sporadic outbreaks from time to time. At the initial treating of the Wuhan outbreak, the spread, such as large-scale lockdown, is already artificial intelligence and also big data in dealing with COVID. Alipay and WeChat is very popular among Chinese population, although it is complicated now to evaluate the success of a particular COVID policy, and it's also hard to say whether the dynamic zero can be a model. There are increasing concerns about this policy, but fairly speaking, it has shown its effectiveness to minimize the influences on daily lives. Yeah, this is my comments on this issue.
Thank you. That's a great way of starting. And in a moment, I'm going to pass the baton on to Dingding to launch our conversation about the US response. But first, I just wanted to see if Alex or Cary had any reactions to the Chinese story that we've heard so far. Do you want to add any very brief comment before we pass the baton on to Dingding to take us into the next phase of our conversation?
I certainly can build on the last point about the, apparent efficacy of the China zero policy, at least as of present. If one compares the number of fatalities from COVID on a per capita basis, let's really look at the outcomes, right? We have a disease that has ravaged the world, 6 million fatalities. Here in the US, we're bumping up against about 1 million, about 970,000. So probably in about 3 or 4 weeks, we will pass the 1 million mark. I mean, just yesterday we had 1,200 fatalities. Now, that works out, our 970,000 fatalities, roughly 1 million, to a per capita rate of about 1 in every 340 people in the United States have died from this disease. And this is not obviously counting, you know, the cases of morbidity, the long COVID cases, and other kinds of concerns, but just looking at fatalities, 1 in about 340 Americans. And if you compare, and I'm using the data from the Johns Hopkins COVID tracker, you look at the data there for China, and you compare 1 in 340 in the US, it's 1 in about 140 or 145,000 in China. So a much, much lower rate of fatality from COVID. And China is certainly not alone in achieving those kind of public health successes. New Zealand has a rate of about 1 in about 85,000. Now, the U.S. also is not alone in being down low. I mean, there are some states like in countries like Brazil and Eastern Europe that have fared worse. The UK is about 1 in 400. Italy is about 1 in 380. I mean, so we're a little bit worse than some other developed countries in Europe, but we could be doing better. Australia, about 1 in 4,500. So anyway, I mean, I think if you look at the data to date, China's looking remarkable. Now, from that same Johns Hopkins data, I will say that the rate of fatalities is increasing as of late over the last month, quite strikingly in China. So, you know, with anything we probably say today, we have to caveat to say, you know, we have to see how all this plays out. We are not out of the woods yet. So a lot of our conclusions about efficacy and so forth probably have to be qualified and made somewhat provisional still.
Okay, maybe let's turn to our American colleagues. You know, the more or less the same question. Maybe I can ask Alexandra first, and then Cary. And how would you two describe the American responses in the last, 2 years and a half in terms of dealing with this COVID situation? Alexandra?
So, I mean, I think the real starting point is the numbers that Cary just gave. We've had over 80 million cases and nearly 1 million deaths here in the United States. And it's really important to remember that those are disproportionately in elderly populations, in Black, Latinx populations. We've had a wave of inequality and injustice in the way that these cases have played out as well. And that really mustn't be forgotten in the size of the numbers. You know, I think you can characterize the US response in general as saying that it's taken a very medical individual approach versus a public health approach. And I'm sure that's not surprising to anyone, but that actually is reflected in a number of ways in which policies and public health responses have played out. So, early on, we had early testing failures that set the US up pretty quickly for failure in terms of understanding the burden of early transmission. There were significant delays across the country at the state and local level and federal level in implementing social distancing policies, delays and lockdowns. And, we know that the earlier you intervene in an epidemic, the smaller the curve, the smaller the impact on deaths, on potential now, as we know, and understand potentially long COVID. There was a slow uptake in masks, and masks are such a symbol of this pandemic in so many ways, and particularly in the United States, the way that they've become a not just a political battleground, but even from the public health angle, how public health leadership have approached masks, as even the examples of at our universities, as the idea that removing a mask is a return to normal. The reality is, masks aren't treatments; they're preventative. They are the classic example of a public health intervention. And so as we go into the next few weeks that I'm sure we'll talk about later, these are the periods in which you do want to be using these preventative public health approaches. And that matches on with a lack of personal protective equipment that we had early on for healthcare workers in hospitals that really impacted the broader societal uptake of masks. So you can characterize so many of the failures as failures of prevention that are fundamentally failures of public health that are also beyond societal ways that we've interacted with these measures. So it's not just about whether these are socially acceptable or acceptable by the broader population. We've seen this in the way Congress has approached funding throughout the pandemic. Right now, the White House has been requesting a $15.6 billion package that has stalled in Congress, and that's as we face potentially the weeks ahead, and that's necessary for the testing, the treatments, these fundamental public health responses that we need. So I think that there is quite an indictment on the way public health has been supported and not supported for very many years, for definitely the last 15 years in the United States, where funding has been cut. And public health capacities have been stripped at the local and state level. And we've seen the implications of that. The final thing I would say is, the United States is a country without universal health coverage. There is not a culture of that sort of social safety net at the scale that is necessary to respond to not just pandemics, but even the epidemics that we've faced for many years here in the US, not just infectious diseases, but for non-communicable diseases and injuries. And so there is a moment in time in which the US needs to think about what this is going to mean going forward. And we've seen the implications of such an unequal and unjust society to date with the numbers that we have.
Thank you, Alex, for giving us a very concise overall picture of what has been going on for the last 2 years. So to Cary, how about from your legal perspective, how has the U.S. government and society as a whole responded to this COVID situation?
I think that's a great question, right? And it really raises a broad theme that we could talk about, is what's the role of law in shaping the response to a pandemic like what we've been experiencing. Alexandra's right, though. I mean, I think we shouldn't leave that behind, that this has become a highly politicized issue. And Neysun referred earlier to some work that he and I did both back in 2020. We organized a cross-country symposium on the regulatory review that brought together about 40 scholars from around the world. And then we subsequently published a smaller symposium in the administrative law review that was also cross-country in its perspective. And I do think, and I want to get to the legal issues, but I do want to say that leadership and politics really does drive a lot of the responses that we've seen in the United States, at least, and I think around the world. A lot of the reason why we were slow out of the starting gate to respond, and quite frankly, still are struggling with masking norms, testing, which is woefully inadequate. It really comes down to a lack of true national leadership. Now, if I can use that to segue into the legal responses, I think a lot of what is inherently hampered the response in the U.S. owes itself to the federal legal structure that we have. As Alexandra said, a lot of our public health infrastructure is at the state and local level. But a communicable disease that, like COVID, is a cross-border phenomenon. It's striking, and I think it's worth noting, in the United States, we did shut down our air travel from other countries, but throughout the entire pandemic, we never shut down the domestic air travel system. It's true that people did use airlines much less frequently in March and April of 2020. But even in the lowest period of air travel, we had 3 million people moving per month during those times in airplanes. Okay, and by July of 2020, we were back up to about 25 million air passengers a month, and we've stayed there. So that just gives you an idea that this is ultimately a cross-border problem, and yet we have a legal structure that is federalist. And what we've seen is that federalist structure has meant that as much as the federal government has tried to develop, the national government has tried to develop a strategy on vaccines, a strategy on masking and public health protections and testing, that's been openly resisted in some parts of the country by some states, and that's manifested itself through litigation where states have challenged national policies. So when our National Occupational Safety and Health Administration adopted a regulation requiring large employers to ensure that their employees were either vaccinated or were testing regularly, it was states that went to court to challenge that. But also we've seen state policies that have prohibited public and private sector organizations from imposing mask mandates or vaccination mandates. So you've had this true tension going on, and COVID is something that, and any communicable disease, quite frankly, is something that if all states don't act in a coordinated fashion, it just won't work. And I will say that, you know, we've seen a Supreme Court here in the United States that has primacy view about how to respond to the pandemic, although it is clear and still, I think, good law that states can impose vaccine mandates on their citizens as a constitutional law matter in the United States. When, again, the states took the federal OSHA to court over its workplace vaccine and testing mandate, the Supreme Court was extremely skeptical that the federal OSHA had that authority, and in fact, ruled against the federal government in that case. And we now don't have a national workplace standard for vaccination and testing because of our skepticism that a majority on the Supreme Court had about whether the federal government has that authority. So that's really, I think, the federal structure is a inherent impediment. It is probably the most, I think, important legal dimension to the pandemic response in the United States.
If I may jump in just to build off what Cary was saying, is, you know, I think really coming down to leadership, it's even though we have these legal dimensions, there still are these powers that are available and could have been used. But there was a significant reticence from federal leadership, both from the Trump administration, and we've seen with the Biden administration to some degree, but definitely in the CDC's leadership across both administrations, is this hesitancy to take the leadership. You know, we have these provisions that do try and make scope under the US code for when you have that cross-border transmission risk, and that really just has not been embraced. And I think one thing that I really like the point that Cary made about those internal travel restrictions, because international travel restrictions are a really interesting dynamic in the US-China relationship, and they also have a broader global public health sort of point that's useful to make, and that is the US really used that travel ban to China early on to essentially what we'd call, you know, global health security theater. It was we've done what we need to do to stop the spread of the virus into the United States, and we don't need to do anything else. And so it really is a classic example of how travel restrictions can end up providing that false sense of security and a justification for leadership to not take action, when in reality, we know that international travel restrictions are incredibly ineffective. In some cases, when they're implemented in a very particular way, they could potentially slow, but really that depends on the local public health response. So when we look at Australia and New Zealand, what we're seeing there is an impact of compulsory quarantine upon arrival, not travel restrictions on their own. And there are many reasons to be hesitant about travel restrictions, and the other one I would point to is the scale of stigma and discrimination that immediate act also played in the United States, and the implications of that for Asian Americans or people in America of Asian descent, and the scale of increasing violence that we've seen in the United States. And that really began with that first seed of a travel ban initially on China. So I think there's some interesting things to unpack there of the implications of how public health responses.
Alex, I don't want to open up.
Glad you mentioned that. Yeah. No, I just wanted to say, I'm glad you mentioned it. I want to be clear that in mentioning that cross-state and that the travel, I'm not suggesting that travel bans are the best way or even a good way of addressing a pandemic like this. Quite the contrary. I do, though, want to recognize that that is the nature of, and we have actually, some really interesting analyses that came out in 2020 where companies looked at cell phone location data, and you could actually observe the spread of people from a single beach in Florida throughout the entire country. That's what people do. They move around, I use those airline statistics, but we could look at just how people get in their cars and move, and there is data that shows along our interstate highways that COVID spread pretty clearly in that way. But I do think so that's the nature of the problem. And how do you respond? Well, it's challenging in a federal system to coordinate, first of all, but I also want to echo Alexandra in saying and that the federal structure also enables leaders to pass the buck more easily, because these public health responses, maybe in China the public is accepting them, but certainly here in the US, they're hard things for politicians, democratically elected politicians, to impose on people. They're not popular to tell people you can't go about your daily life. You have to take a vaccine that has, well, some side effects, mild certainly, but some people don't like needles. And, these are unpopular actions. Anytime we think about the authority of the state needing to intervene and impose requirements on people, it means they're asking people to do something that they're not volunteering to do themselves, right? And as long as you have the ability for, President Trump, who did say it's not my responsibility, and governors to blame the federal government for the failures, and everybody can kind of blame each other and no one takes responsibility. In some sense, there's a challenge that when everybody is responsible, no one is responsible, and you get the very possibility leadership vacuums, or at least if you don't have the right kind of leader who's willing to step in, and certainly you've seen this, I think, in New Zealand, for example. You've seen an example of a prime minister who really has stepped forward and followed the public health playbook, even though it has been unpopular.
And just on this federalism point, Alex, I was going to say, I don't want to open up too big of a new vista, but at the same time, given that you are from Australia, and I know you've been following that case very closely, as you've helped me to understand, Australia is, of course, a federal system, maybe not exactly the same as ours, but it does beg the question of whether, a federal system necessarily has to have the same kinds of, defects in its approach that Cary has so nicely laid out in terms of our U.S. response. Could you just maybe say a little bit about, whether, the Australian response is the same playbook that Cary has just described for the U.S., or has it been something a little bit maybe more intrusive, but still consistent with the federal structure?
So it's a really good question, because there are actually a lot of parallels at that federal level, and in fact, to take any responsibility, to take any measures. And I guess the saving grace has been the fact that you have state leaders who have stepped up into that vacuum. And so states that such as Victoria and New South Wales, Queensland have had very different types of responses and levels of restriction. Same with Western Australia, that has only recently just opened its domestic borders. But what we saw was that use of domestic borders in a way that we did not see here in the US. There actually was a recent study that came out looking at global measures and saying that those domestic restrictions are actually much more effective than, say, international restrictions. So not just in terms of border closures, but we saw state leadership step up in terms of testing, in terms of the vaccine rollout. And what was really lost, so whilst we thankfully haven't had that vacuum, what was really lost in that process was accountability for the federal government in the fact that they did not take steps. There were 40,000 Australians stuck overseas who were not allowed to go home or couldn't get home. The benefits and the centralisation of federalism, really we lost that because there wasn't that leadership. So thankfully, we had the state government step up, but there could have been a lot more efficiencies and potentially lives saved as a result if the federal government had taken their responsibility and their duties seriously.
I should add that Canada is also a federal structure, and they've done better than the U.S. too. So one has to be careful here not to say that everything that's gone wrong in the United States has gone wrong because of federalism, but it is an inherent, I think, structural obstacle or impediment.
Well, if we take the lens back to China, of course, China is not technically a federal structure, although many of us scholars of Chinese law and politics have often said it's a sort of a de facto federal structure. That's maybe another discussion for another time. But it is, as you've said, both Ma-Yun and Tsai, it's been a case study of very strong leadership from the top. One of the components of the Chinese response has been, we've been talking so far about sort of travel restrictions and maybe the lack of travel restrictions in the US. China has had a very strict border control element to their zero COVID policy. That also within China, that domestic travel wouldn't be quite as, if you're from Beijing and you go to some other part of China and then you test positive, then it's going to be hard to get back into Beijing. I think there's some people who complain about. So all of this is to say that I think there was some sense that maybe China was going to start relaxing its zero COVID policy because of various kinds of considerations about its costs. But at this very moment, there are more cases throughout China than at any point in the crisis. And so I wonder if both of you could say something about whether, this current surge of Omicron cases, which is felt particularly in Hong Kong. We know that Hong Kong is having a really tough time now, and that's partly because of the lack of vaccination for elderly residents in Hong Kong. But could you both say something about whether, there is going to be some change as you perceive it in the China's COVID policy going forward, or if the moment right now is maybe going to keep the existing approach in place for longer than we might have thought even just a few weeks ago? Maybe Tsai, do you want to go first, Tsai?
Yeah, sure. We have seen there is a little bit of change of the policies, but the top leaders still consist that we will not change the COVID zero strategy. And I think that is a very important thing, because we analyzed the different countries' government response based on the Oxford government response tracker. And it is very important thing is you have to implement policies consistently. So we have seen that the Omicron variant variant brings a lot of symptomatic cases. So it looks like maybe it's not that serious than before, but we have no evidence and we cannot predict how the virus will become. So it could be more serious in the very near future, especially the Hong Kong's outbreak. So I understand that maybe we will not change the COVID-0 strategy, and also because it's a transitional strategy to implement 3 or 2 weeks. So, but they still changed a little bit. China started to ask people to do self-test by anti-agent test kit. If they can buy it from the pharmacy or online, and they can test it by themselves. If they test it within the 5 days, if they have some symptoms, and then there is negative, they don't need to quarantine for 14 days than before. So usually they have to be quarantined for 14 days. And also for the discharges, they don't need to be quarantined for 14 days. They just the time is to 7 days, or they even will not send the patient with no symptoms to hospitals for some kind of treatment, maybe traditional Chinese medicine treatment. They will be quarantined as the other patients, other like suspended people as well. So we can see that there is a little bit of a change of the treatment plans and the quarantine plans. So we still think that we need more evidence to prove that the variants will not be more serious in the near future. Yes, so I think the COVID-0 strategy will still be not for at least maybe 1 year.
Ma-Yun, how do you see it? And do you think that the regulatory apparatus is sufficient to take into account, a fluid and dynamic situation and potentially adjust if the possibility is there of lessening some of the restrictions?
Yeah, I think Cary has mentioned the recent changes, and I also agree with her. But to me, I think the signals has released is not minor changes, as she has phrased. The National Health Commission released the most updated protocol for COVID-19. I want to add one more information is adjustment of the criteria in defining positive cases, which is much lower than the previous threshold. The CT value is decreased from 40 to 35. So this means that the ones that would be previously tested and reported as positive may be deemed negative in the future, and this change may decrease the affected numbers largely. So in my opinion, although the zero COVID policy remains unchanged, and this has become kind of a propaganda and a rhetoric value, but the standard of zero is already lower than before. What I also want to mention is that this shows that in risk governance, there is never a bright line between science and politics. So how the protocol changes the CT value and define the positive cases is kind of a response. I think it has released positive signals of a loosened policy may come soon. And another one, just as Cary has mentioned, is about the antigen test. I think once the zero policy will be relaxed, the citizens will have more chances to have early detection and monitoring themselves. This is also a signal of a relaxed policy. So this is my general comments and my observation of recent changes from the Chinese side.
Okay, thank you, Professor Cai and Professor Ma, for I think offering a very compelling picture explanation of what's going on. And I would just maybe add one small comment. I think whether to change the policy or relax the policy would of course, both international situation and the domestic situation. So if internationally all countries are opening up, and if that's the case, you don't see more new variant coming up, then maybe also it's time for China to slowly, selectively to open up. And one piece of statistics is that in China, for people who, for the older people who are over 80 years old, the vaccination rate is only 20%. So this number has to go up to maybe 80% before, I mean, the government can make some real changes, because the elderly people are the group that would suffer the most because of the COVID. But anyway, I think the overall trend is toward more relaxing and more opening. But of course, maybe there is still a long way to go to full opening. But I want to go back to the US case, because the US has also made some recent changes. I think both Alex and Cary and also Neysun mentioned, for example, no masks maybe in University of Penn and other universities, so on and so forth. But of course, a lot depends on the state level. Maybe different states have different policies, but overall, it's following maybe what's happening in Europe with the full opening, even without testing. And but of course, we still need time to see what kind of consequences would emerge out of these new changes in the policies. And of course, there's also new development in terms of new variant of the virus, Omicron, BA, .1 or even BA.2. Who knows, right? Maybe by winter this year there will be some new variant again. So I wonder how, Alex and Cary, how do you see the U.S. new adjustments? Do you think that's going to be permanent, or it's going to be conditional?
So I think, as a general statement, there will be a hesitancy and an unwillingness to be reimposing measures unless something really significant changes, such as, if unlikely with the BA2 possibly, but if we have a new variant that would outweigh that scales, I think political leaders and particularly at the federal level have been quite hesitant, quite wanting to move towards this idea of not necessarily normalcy, because we're not going to have normalcy after 1 million deaths, but that things are getting better. So I think it's also a little bit too early to tell what the implications of BA2 are going to be in the United States. There are lots of differences between the US and Europe in terms of what the last 4 or 5 months have held in terms of measures. The US has been unwinding different mask mandates at different levels for a longer period of time. We have widespread use of mRNA vaccines, which makes us a little bit different to the UK. So the parallels of thinking, well, we're going to be 2 weeks or 4 weeks after what we see in the UK or the EU. Is not necessarily the guarantee or the certainty that we had previously. We've had schools open. So there may be have been more Omicron BA1 cases that may impact what we actually see with BA2. So more people with more recent infection, perhaps more sustaining immunity from the boosters. That being said, only 65% of the US are fully vaccinated or have had 2 doses. 96 million have had the booster. So there is quite a gap that we know that the slightly increased transmissibility with BA2 over BA1. If we do start to see a surge in cases and the spread across into unvaccinated or lower vaccinated populations is where we might see that surge. So it is still a little bit early to tell, and we don't really have that rule of thumb of 2 weeks or 4 weeks after UK and Europe, because there are a range of different variables. But even so, I think ideally the most basic entry level implementation measure that would take place would be a reintroduction of mask mandates. I think it's also a really good opportunity to point out the difference between what a legal mandate and what compliance is. So, for example, in New York City, we haven't had a mask mandate for quite some time, but most businesses still require that you wear a mask when you're indoors. If you're at a restaurant, when you're not eating indoors, to be wearing a mask. People have a general compliance because of the impact of the early epidemic here in New York. I think there's culturally a bit more of an adoption of wearing masks generally. So it's important to extrapolate between what is the legal mandate versus what is actual compliance on the ground. And so the dropping of mandates doesn't inherently mean that you won't have compliance, including, for example, in classrooms at Georgetown where I am, maybe students will continue to wear their masks inside despite the dropping of the mandate. So, there's a lot to be looking at going forward. I think the biggest question will be will Congress actually step up and provide the funding that the White House has requested for testing and treatments, because that will be a huge gap in our public health response if that doesn't occur.
I think where we're at today can be captured in one word: waning. And that's both in terms of the efficacy of the vaccine. So we can have, certain rates of full vaccination and even people being boosted, but we see that Pfizer and Moderna, the manufacturers of the mRNA vaccines, have gone to the U.S. Food and Drug Administration just this week to ask for emergency use authorization to recommend, in Pfizer's case, a fourth shot for anyone over the age of 65. In Moderna's case, they're asking for an emergency use authorization for that fourth shot or second booster for anyone. And we do see some indications that the efficacy of these boosters even are waning over time, and people are starting to reach the 4, 5, 6 month mark, even if they've been boosted. People who are fully vaccinated may be reaching about a whole year. So what has been the predominant and probably the most efficacious intervention in the U.S., the development and use of those mRNA vaccines, that efficacy seems to be waning. At the same time that we are seeing that the BA.2 subvariant is indeed finding its way into the U.S. We have indication in wastewater analysis and in certain analyses of patients that this is now finding its way into the U.S. So it is coming. And as you have said, Dingding, there may be another variant along the way somewhere else during the year. So we have the waning vaccine in the face of the possible threat of new variants taking hold. And there's also the waning, I think, of public support, patience, and willingness to sacrifice much. It goes back to my earlier point about federalism. It's kind of instructive that it was actually relaxation of these mandates occurring at the level of states, even before the federal CDC sort of relaxed some of its masking recommendations. And I just don't know that we have the political will going forward, unless there's something that really dramatically leads to a lot of fatalities for healthy people in majority kind of racial composition groups, younger people. If there's unfortunately, I think, a waning of resistance by the public to this. I mean, when we have 1 million fatalities, there's a numbness that has set in. We're not out of the woods yet. We're at 1,200 fatalities still per day from this disease. If this were to get down to a more endemic level akin to influenza, we would need to have fatalities dropping down to about 160 or so fatalities per day. We're not even close to that level. And yet, so many people are back to normal. Our president is interacting without masks in crowds of people. We have the the former president, Barack Obama, getting infected. We have the husband of our vice president infected. It may be a matter of days before we see other top leaders reporting infections too. And that I mentioned that just as an indication of how many people feel like we're over COVID. We're just over it, and they've lost their caution and vigilance. And if we don't have the vaccines working well, and we don't have a public that's as vigilant, then we're looking at, I think, a distinct possibility of another major surge in the months ahead.
I think it's a good moment to say that for folks that haven't had their booster, now is the time to go get your booster shot.
We offer comparative U.S. and Chinese analysis and also public health messaging in this episode. I was just going to say that it's so interesting thinking through the conversation so far about so many aspects, but just on this point that Cary was just emphasizing about how the political culture, the sort of general sentiment in our American society is, I think, as he correctly characterized, one of we're over it. And that creates a kind of a pressure for political leaders. I think from what I understand, there's almost a exactly opposite dynamic in the Chinese context, where there's so much concern about the potential effects of getting COVID that it puts another kind of political pressure on leaders not to relax too quickly. And I don't want to think of it in terms of culture in some kind of essentialist way, because I think culture is constructed. But it is interesting to contemplate how whatever choices went into the response or other things that have happened in the past have sort of created this dynamic where there is a political pressure on Chinese leaders, there is a political pressure on US leaders, and they're exactly opposite political pressures. Is sort of fascinating. But we are starting to reach towards the end of our conversation, and something that we always like to do is invite all of our guests to offer their recommendations for the future on the topic we've been talking about. So why don't we do first a round robin here? We can start with our Chinese guests again. From your vantage point, having looked at this issue over the last couple of years, just thinking about the domestic response at this stage of our conversation, are there any things that you would like to see implemented in the future that could maybe better address a similar kind of issue that comes up in the future? Saeed, do you want to go first?
Yeah, sure. Actually, I did in the domestic environment. I think we still have a lot of issues to face. For example, the prevent domains, the detect issues, and the response simulations. We all have to plans to fix these problems. As we say, we do not have a very strong primary healthcare system to prevent all of these things. And the detections is not, the detection, like the data collections is not as good as enough. Based on the emerging infectious disease, it's related to One Health. It could be from the zoonotic disease from the animals, and we have to merge the different sectors' data together. But it's very difficult, even though in the healthcare system. So when we do some surveys to different counties, and the healthcare system, like the hospital information systems, is totally different. They buy the services from different IT companies, and then the indicators are different, and it's very difficult to merge all data to do analysis. So for the emerging infectious disease, it's very difficult to identify the outbreak very like rapidly and at the early time. So this is the biggest challenge to China to face this. And I see like the Hubei province has started to develop the detection system. to have a better alert and issues. But I think it's still very difficult to merge. Even to merge the whole of government sectors across sectors to merge the data. And also we have developed a kind of good ways to have a whole of government governance. For example, the state council's joint prevention and control mechanism, and it's for the pandemic time. And we can see that the National Health Commission take the lead to run this mechanism under the state council. But after the pandemic, how we can make each sectors, government sectors, to come together to make the response plan to simulate periodically, for example, for per year or 3 years, and each province should have the plans to collaborate, to coordinate, and also the domestic plans should coordinate with the international plans and across countries. So I think there are a lot of things we have to do. And the most important thing is like we have to develop the primary health care, and each community health centers you have the fever clinics. And the big issue is we have to train more qualified health workers for the future.
That's such a great point, and I can't resist just interspersing a point that one of the things that both Cary and I have thought about and written about is the way in which the pandemic has revealed particular vulnerabilities that are particular to every society. And so there's certain things in the US that we have come to see that both Cary and Alex have said so nicely today about maybe inequities in our system that came to light because of the pressure of the pandemic. And I think anyone who pays attention to public health in China knows that there were some existing vulnerabilities that the pandemic has brought to light and that maybe can be an agenda for reform in the future. So Ma-Yun, how about you? What are your big ticket recommendations going forward?
Okay, thank you. I want to draw back to the central-local relationship a little bit. I think although it seems that the centralization strategy in China has shown its advantages of dealing with this COVID, but I want to mention some loopholes and also some structural obstacles and impediments that I have observed about the central-local relations, especially about the considerable disparity at the local level. I mean, the organizational capacities, the wisdom of the leader, and also their ability of targeted prevention and control, etc. Also, the sense of the rule of law of local officials are so different. And the recent outbreak in Jilin province has shown that the local officials are not prepared to move fast, and their performance in the outbreak is quite unsatisfying. So there are still a lot of considerable loopholes to be fixed up. In comparison with these bad performance cities, we also have metropolitan cities such as Shanghai has made very good examples. For example, 20 square meter milk tea shop in downtown Shanghai was delimited as a medium risk area and is tagged as the world's smallest medium risk area for COVID and received a lot of netizens' applause. However, it is fair to say that there is seldom any city in China that is comparable with Shanghai, with the wisdom to make such a risky decision. So looking into the future, I think the first step for Chinese government is to rectify local wrongs because the state of emergency has been taken advantage of by Chinese government during COVID responses. However, from my opinion, it's apparently abused. Governments have used this blanket authorization as a shield to shirk responsibilities. And the central task for China is to rectify local wrong and also to curb the overreacting of local governments so as to rebuild the authority of law. And the phenomenon of layer by layer overweight and also one size fits all in the implementation of policies in some localities has already become common practices. And I think there is an apparent gap between the central order and also local implementation. But I would rather name this phenomenon as a cat-mouse game, because what we see in media is local officials are routinely dismissed and castigated for the outbreaks in their jurisdictions. But we seldom see any local official who adopts a one-size-fits-all policy, who adopt a stricter containment measures that are held accountable. So there are reasons to explain the local officials' choice of behavior, such as a high-pressure accountability system has pushed them to pursue for absolute safety at the cost of individual rights and conveniences. So I think looking into the future, first we have to monitor localities' path dependency of the pressure-based approach and adjust them to a law-based one. And another recommendation from my side is we take advantage of the state of emergency, but between the state of emergency and the normal state, there is a fuzzy middle ground and a buffer zone. And under the edge of digitalization, there is a great risk of a normalization of the state of emergency, especially the digital technology is already embedded in our digital infrastructure in the nation's digital agenda, especially all the big data and also the health code used now have already caused a lot of serious concerns about over-collection of individuals' personal information. So how the usage of this kind of technology will be changed under the new normal status, and considering the discussions now on the right to be forgotten, whether citizens are empowered to claim the deletion of all their information collected by all levels of governments, and these are still questions to be resolved. So these are my general recommendations and mention all the questions I think that are worthy consideration in the future.
Fantastic. These are fantastic recommendations. You and Cai have set a very high bar for Alex and Cary. So let's see how they do. Alex, why don't you go first? Your recommendations.
So I think in the immediate short term, we need a national strategy a national campaign to build up boosters and get that vaccination level up from 30% and get that booster coverage up urgently. I'm talking within the next sort of 2 to 4 weeks. It's going to take some time to build up that immunity with the booster. We're already facing BA2 in the United States, but this is also about preparing for the next variant. That has to be an urgent priority at scale. Similarly, with masking, the reality is if the CDC backflips again and imposes a policy, it's not going to be complied with. And as I agree with you, the culture is not essentialist, it is built. And there's an opportunity for public health risk communication and a really strong national public health strategy about masking to protect others. Actively move away from this idea about individual risk and actively try to build a culture about masking and other low risk activities like meeting outdoors and things like that. So that's the immediate short term, and that's urgent. There is also other short term, but probably more medium short term responses, and that is the fact is we will have another pandemic, and it may be much more severe than this one. We can't say that we got lucky with 1 million deaths in the United States, but we know that the risk of severity of the next pandemic, particularly say an influenza pandemic, is quite high. So we need to be urgently tackling the societal level changes that need to prepare us for that next pandemic, and that have a range of health co-benefits beyond pandemic preparedness and response. And first up on the list is universal health coverage in the United States. We need to build primary healthcare capacity and build a culture of accessing primary healthcare, because we know that the best surveillance system you have for the next outbreak is not some magical test or tool. It's a switched on healthcare worker. It's the nurse or the doctor who picks up on something odd and responds and reports it quickly. It's really important, similarly, that we don't get distracted by high cost, low reward measures. I think there's a lot of attention on how we can stop spillover at the source. The reality is outbreaks happen all the time, spillover events happen all the time, and you'll never be able to stop them all. What stops an outbreak becoming an epidemic becoming a pandemic, is strong health systems. And that's an international effort. We have moves like the pandemic treaty proposed, potential reform to the international health regulations, another piece of international law for responding to epidemics. We need to be building up that global coordination capacity, and the US has a leadership role to play. And in many respects, so does China, in helping build global capacities to strengthen health systems around the world and develop regional vaccine production, so we don't end up, when the next pandemic happens, end up in the position that we ended up in now with vaccines.
Great, Cary. Lots of good ideas there. Do you have more?
Yeah, certainly I agree with everything Alex has said. Let me highlight two measures going forward in the US, whether, with response to the current COVID outbreak and pandemic or future ones. One is testing. We have been just flying blind, really, still 2 years out, going into the third year. We've circulated a lot of at-home tests, but in some sense, that, as helpful as that can be for personal decision-making, because those at-home test results don't get reported, it means that decision makers are still far too much flying blind. So we have about 30,000 cases being reported today on a daily basis in the US, but that's surely a fraction because people are getting tested now at home. So, and I should add, by the way, Neysun mentioned at the outset how the university used the University of Pennsylvania as an example of having relaxed some of its masking requirements. It's also relaxed some of its testing requirements. And that's just emblematic, I think, of how we have a great need for more data if we're going to really manage these well. And I guess that leads into my second point, which is I think there is need for substantive legislation at the federal level. Yes, we do have some public health legislation that gives the national government some powers, but what we have seen is that when the federal government has tried to exercise that power in ways that are appropriate to meet the moment, but different than what the federal government has maybe historically done, both in the OSHA vaccine or test mandate and in the CDC's eviction moratorium case, that the Supreme Court has been very skeptical that the Congress has given the federal government those powers. Now, I don't see anything in those Supreme Court decisions that suggests that Congress could not, if it did so clearly enough, give the national government that kind of authority. And I guess if I was to weave together both the testing point and the new clearer legislation point, maybe one place to start would be to get for Congress to pass legislation that would give the national government a clear mandate to require testing throughout the whole United States. And that, it seems to me, would be at least one positive step forward to put us in a better situation going forward into the next pandemic. Now, it doesn't solve the leadership problems. And, it was the National Food and Drug Administration and CDC that botched certain aspects of the testing at the outset in the United States. So it's no panacea, but I do think there are and should be ways of clarifying a national coordinated responsibility and authority in legislation. And it seems to me the Supreme Court has all but said you have to do that if we're going to handle these kinds of outbreaks responsibly in the future.
Excellent. So I think we have a lot of excellent recommendations. The harder part is, of course, for our respective governments to follow through these recommendations. Of course, it's not, if you look at the whole world, it's not just China and US. There are other countries that, they have different conditions, different policy recommendations. So how to coordinate internationally is really a big challenge for all countries. But anyway, I think all of the recommendations by our four speakers today are excellent, and we do hope we can achieve a more positive future. Neysun.
Yeah, I wish we could keep going. This is such a fun conversation to have with all of you, and a dimension that I am very interested in. Maybe we don't have time to get into today, is whether there is some positive dynamics between the US and China cooperating on public health that could be realized in the future, and whether that would be a kind of a recommendation. It's clear that the US and China cooperative dynamic has been particularly poor over the past couple of years, and it's hit right. COVID-19 has hit right as that cooperative dynamic was particularly poor. Of course, whether or not there is any runway for a more cooperative dynamic may rest in part on the phone call that just happened this morning that we alluded to at the beginning of our discussion. So maybe we can wait and see how that phone call went before we can come up with a set of ideas about how the US and China can cooperate better, at least on public health, in ways that can, as all of you have said in your wonderful recommendations, better prepare us for the next public health crisis, which of course we all know is coming. But we've already talked about so much, and we are so grateful, both Dingding and myself, to all of you for joining us. We don't want to take up more of your time, and especially, I know Ma Yun has to navigate through a snowstorm in Beijing right now, so we should let her do that. Thanks all of you for participating. Thanks so much to our audience for tuning in, and please stay tuned for our channel for more discussions like the great one today coming soon. Thank you all.